Today's webinar is Opioid Use in Pregnancy, presented by Dr. Maria Muzik. It is a free educational event and is brought to you by the Northeast Delta Human Services Association and Louisiana Department of Health, Office of Behavioral Health, and Foundation for Wellness. It is accredited for 1 hour for AMA PRA Category 1 credits, LPCs General, Social Workers Clinical, and ADRA. For more information on accreditation information, please head to our website. Neither our speaker or the planning committee members have any financial disclosures. A little bit about our speaker before I give the floor to her. Dr. Maria Muzik is a professor of psychiatry and obstetrics and gynecology at the University of Michigan. She holds a medical degree from the University of Vienna, Austria, and completed residency in psychiatry both at the University Hospital in Vienna and Michigan. She also holds a master's degree from the School of Public Health. She is board certified in psychiatry and addiction medicine. Dr. Muzik is the medical director of perinatal and reproductive psychiatry at Michigan's Medicine University of Michigan and of MC3 Perinatal, Michigan's Perinatal Psychiatry Access Program for Primary Care. At Michigan Medicine Psychiatry, Dr. Muzik co-directs Zero to Thrive, a program to support families who are challenged by adversity to help them thrive across pregnancy to postpartum. She is also the perinatal psychiatrist for the Partnering for the Future clinic to support perinatal persons with substance use and opioid use disorders. She co-developed the Strong Roots programs, a menu of resiliency-oriented interventions. Her research work focuses on the impact of adversity and mental illness in the context of childbearing on caregiving and developmental parent-child relationship, and how to support families in overcoming psychological and environmental adversity. She is well published, and her work is funded by federal, state, and foundational awards. So thank you so much, Dr. Muzik, for being here.
Thank you so much for this wonderful welcome. And I'm so honored to be here today to speak to you. So I'm going to share my slides and let's get started. So I want to talk with you about a topic that is really dear to my heart. And that is opioid use in pregnancy. As you heard, I'm a perinatal psychiatrist and addiction medicine doctor and work with pregnant persons and postpartum persons who are impacted by this condition. And so I really think that this is a very important topic. And how do I advance now? Oh, yeah. So what do I want to discuss with you today? Briefly, just kind of to get the outline. Why does this matter? A couple of stats. Then what is opioid use disorder? What are the basics of diagnostics? How do you screen and identify? And how do you provide comprehensive care? So let's start with why does it matter? And I want to make an argument that this is a big issue for maternal morbidity and mortality in the United States. This is a slide to show you the mortality rates across. So it's how many deaths, mortality per 100,000 live births. And this is comparing it to other countries, Western industrialized countries. For example, you have here Norway, Switzerland, Sweden, the Netherlands, Japan, Australia, Germany, United Kingdom, France, and so on. And you can see, or Canada, our neighbor, and you can see it's in the range of, one digit, 8 per 100,000. And then you come into the US and you see it's on average 22 per 100,000. And it's not equally distributed. When you then sub-select and see, what about African-American women in comparison to white women, Hispanic women, or Asian women, you see that Black women, it's 49, almost 50 per 100,000 deaths, maternal mortality. Whereas white women would be 19, Hispanic would be almost 17, and Asian women 13. So you see that we in the US, despite this industrialized country and advances in medicine, we have the highest mortality rates for women in this perinatal period that outranges every other industrialized country. And it's particular women of color are dying with higher rates. And then you ask yourself, so why is that? What are the causes for this pregnancy-associated mortality? And again, you would think, well, maybe it's all the medical conditions like pregnancy-associated, either not related or related medical conditions. And yeah, they play a role altogether, almost 37%. But then when you look at what is actually the number one item, it is substance use disorder. So 29% of maternal mortality is due to overdose deaths. And then shockingly, you see that almost 13% are due to homicide, so interpersonal violence, exposure, homicide, and then 5% are due to suicide. So these are together numbers that are basically almost 50% and definitely preventable. So let's talk about the opioid crisis because that's the main driver of the death, and I will show it to you in a second. But as you know, we have these waves of opioid overdose deaths. It started with prescription opioids. That was in the beginning, in the early 2000s. We had the first wave of opioid death. Then came the second wave when basically the pharma companies, Purdue and such, the Sackler family got basically sacked and identified as criminals. And the prescription of pain pills was restricted. Individuals were not offered treatments actually and alternatives. So there was a rise in heroin use and heroin overdose. So you see that's the blue line as it starts going up. But what you see that over the last 10 years, what really is driving the death rate is synthetic opioids. The new kind of developments of synthetic substances. So just as a terminology, what are opioids? And you might notice this is just kind of a refresher. We call the natural substances that are coming from the poppy seed, from opium poppy, the plant, which is morphine, codeine, and heroin, we call them opiates. But everything that is synthetic or semi-synthetic produced in the laboratory out of those initial natural substances we call opioids. And so the opioids are, of course, our medicines like methadone, all the pain pills that are, oxycodone, hydrocodone, pethidine, fentanyl, and then also buprenorphine. Now, these are synthetically chemical structures that are produced. And now we have the newest wave of these new synthetic opioids that are even much more potent than fentanyl, which was already much more potent than heroin. And we have, the newer one, like the nitazines. And then actually kratom is like a special substance, mitragynine, because in low doses it works like a stimulant, but in higher dose it attacks the opioid receptors. So just to highlight that point about potency, if you look the potency of morphine to fentanyl to carfentanil, you see that what so fentanyl is like 100 times more potent than heroin, but now carfentanil is 100 times more potent than fentanyl. And so it's really microdoses, microcontaminations lead to effects, including respiratory suppression, and that can cause death. So you see that carfentanil was initially a tranquilizer used in veterinary medicine for large animals like elephants, but that 2 milligrams knocks out an elephant, but it can kill 50 people, like these doses. So this is very important, and that's what we are kind of dealing with. And the newer synthetic ones are even more potent now than carfentanil. And this is where we are now in terms of the deaths. So you can see that from 2017 to 2020, we had this huge increase in uh, death rates, and that they are mainly driven, as I was saying, the curve goes up through fentanyl and other synthetics, and that unfortunately more and more they are also paired with psychostimulants. So the combination of a like cocaine with fentanyl or opioids, or the where it's laced with these substances, or it's intentionally mixed, is rising and leads to overdose deaths. And similarly, what is the time when in the perinatal period is a particular risk, and you can see that it is specifically in not, I mean, pregnancy, of course, is also rising, but it's not in early postpartum. It's particularly in the second half of the first year where pregnant postpartum persons might die by overdose. Why is that? As often during pregnancy, consumption is reduced, or you are on medication-assisted treatments, and then people might stop, and the receptors get desensitized through the use of medications, and then return to use at the same dose or even a lower dose could lead to overdose death. Or, as I said, it is laced with contaminated with fentanyl and such. So, as said, we are currently in the United States having two big crises. One is the opioid crisis, and that's the overdose death, and the other is the maternal mortality crisis, and they are basically kind of impacting each other. And the one of the aspects of untreated opioid use in pregnancy is really detrimental for the mother, the child, the mother, the pregnancy, and the child. So just to kind of think what are the impacts for the mother is, well, often it prevents them to, or they feel prevented. And I can tell you that fear of having being treated unkindly or being punitively treated, is one of the drivers of prenatal care. But then in terms of pregnancy impact, substance use, opioid use in pregnancy is related to complications of pregnancy, like placental abruption, preterm labor, of course, infection risk, miscarriage risk, of course, overdose and death risk, other high-risk activities that might lead to injury or violence exposure, co-occurring mental health conditions because of the chronic stress, and as well as the impact of the substance on the brain, polysubstance use or co-use with other substances, and then for the fetus, or the child, stillbirth or structural anomalies due to the substance use. Of course, there are certain substances that are much more clearly causing structural anomalies, malformations, like alcohol, but nevertheless, we also see that the rates of malformations with opioid use is increased. And then the fetal growth restrictions because of perfusion problems due to the substance. Again, particularly if there's co-use with stimulants or vasoconstrictive substances like tobacco, nicotine, and then the neonatal withdrawal symptom, very, very prevalent with opioid use. Number one reason for not seeking prenatal care in birthing people using substances is fear. And the fear is of criminalization and reinforcement of stigma. The fear is that as you know, currently in the landscape of the United States, we have 25 states and DC already considering substance use and as pregnancy child abuse, and there is criminal charges, and then the stigmatization, the fear of child protective services involvement that is not supportive and helpful, but is punitive and leads to automatic terminations of parental rights or separations, is limiting persons to come forward and seek help. Okay, so moving on to what is now an opioid use disorder, and what's the definition? So, and why are people kind of using opiates or opioids? Why is it historically over hundreds and thousands of years used for recreational use? It's because of the analgesia and the euphoric aspects. As said, whether natural or synthetic or semi-synthetic, it always is the same mechanism. It works through different opioid receptors that we have in the brain. We have mu and kappa opioid receptors. So why would the human brain naturally have opioid receptors? Well, because we have endogenous natural opioids called endorphins that are actually produced and there are triggers for production of these endogenous opioids. Is stress, pain, exercise, sex, food, dark chocolate, massage, acupuncture, connection, physical contact. Well, because these are actually important for our well-being, these endorphins, and basically the opioids and opiates are now the even more potent kind of analogs of these same endogenous endorphins. And they create exactly what I said. They help with pain, so they inhibit pain, they cause euphoria and reduce anxiety. That's why we have those endorphins, and that's why people are drawn to using those substances. So the desired effects, we already said, of opioids is pain reduction, euphoria, and reduction of anxiety, or called anxiolysis. The additional effects that you see on the body is that it's constricting the pupils. So that's how you have to pinpoint pupils. It changes mental status. It can cause sedation, euphoria, and then eventually sedation. It decreases bowel movement and creates constipation. So we have also opioid receptors in the bowel. It's ubiquitous across the body. Hypothermia, it slows down the heart rate and it slows down the respiration. And that's why people die. They stop breathing and fall in a coma. Okay. So what is a use disorder? A use disorder we now in our Diagnostic and Statistical Manual, DSM-5, we are basically differentiating between misuse, and then misuse quickly goes into, for some substances, into a disorder. It's a problematic pattern of opioid use that causes significant impairment and distress. And it requires at least two of those. Total, we have now 11 symptoms that we basically put out there. And if you meet those, if you have all 11, then you are severe. If you have more than 6 of those, you have a severe opioid use disorder. If you have 4 to 5 of those, you have a moderate one. And if you have only 2 to 3, you have a mild one. And important is in a disorder is that you develop physiological symptoms, such as tolerance. That means that the same dose does not have the effect anymore. That means that you have to start increasing the dose. Why is that? Because the receptors get used, or we call it, they are sensitized. They get used to the substance, and you have to basically upgrade the dosing in order to have the same effect. That's called tolerance. That's how you develop. Then when you stop this substance, now you notice it because now you have desensitized receptors and now they're missing the substance. And that's what withdrawal looks like. That's a characteristic syndrome where you have now the opposite of the effect that this substance had, and you notice these withdrawal symptoms. And then these are other symptoms of use disorder. It's hazardous use despite health problems, having cravings, urges, unsuccessful attempts to cut down, excessive amounts of use, excessive time spending, and kind of using, checking, seeking the drug, or recovering from the substance, missed obligations, interfering with activities of work and personal life. All this is a package. So there is a behavioral component, as you can see, a cognitive component, and a physiologic component of the disorder. And why is that? Why is all this craving and all this kind of use and what is happening, the psychological and cognitive? Well, it is a lot has to do with our brain reward circuitry. So as I said, we have these endorphins in the brain. Well, where are they attaching? Well, we have a natural rewards brain circuit. It's called the limbic reward system in the brain that is kind of in the middle of the brain. It's like an older region of the brain, the amygdala and the ventral tegmental area. And it is controlled by the frontal cortex, which is our, thinking and abstraction and higher order thinking. But it's not, it can override the prefrontal cortex. So if this area, this limbic reward circuitry, which is there, is working through a substance, a neurotransmitter. Neurotransmitter means a substance that is like connecting the information from one nerve cell to the other in the brain, from one neuron to the other through the synapse. That's the cleft in between. It's all dopamine. Dopamine is the neurotransmitter that's important. And you can see that naturally, when you have pleasurable activities, you have neurotransmitter release that kind of gets that reward circuit heightened. So if you have good food or sex, you have a certain dopamine release. But then you see if you take substances like cocaine, opioids, that dopamine release is much higher. Heroin, even higher. And then you see methamphetamines, actually, crystal meth, the highest. But now the synthetic opioids also very high dopamine release. So that's why the brain gets hijacked. The longer you use, when you have chronic use, these neurocircuits become like highways. And it's hard to unhighway, so kind of make these little roads, they become highways, and now everything is, you're basically reward seeking after certain use, time of use. And so that's why it takes so long to kind of get the brain again in recovery. It takes a long time to kind of lose those cravings, and you might need some medicines to help with that, to calm this brain circuitry. So that's the physiological and kind of neurobiological underpinning. So how do we screen for use disorder? Well, what is screening and what is the difference between screening and testing? Because screening is not doing a urine drug test, although we call it UDS, urine drug screen. But actually screening is a series of questions asked the patient about their use. And the American College of Gynecology and Obstetrics recommends that everybody gets screened about substance use. Similarly, that everybody should get screened about their mental wellness, and that would reduce inequities in just doing testing, unilaterally with certain groups. So screening should be done to everyone, and testing is now doing a biometric assessment either in the urine or in the blood to confirm to either detect all the substances that I used or to confirm the use of these substances, and should not be done without consent, like punitive, I catch you, but should be actually done like a medical test that can be then discussed as a basis for a discussion, and that is collaboratively leading to treatment decisions. So that means, what are the screening tools? So I don't know. I work in an OB clinic that is integrated with for individuals with OUD and SUD, and we start with the, some people use the 4S or the 5S, but it's basically the 4 or the 5P questionnaire. Might have heard about that. You start kind of asking, come from the outside, the circles of social connection, and asking, did your parents use when you were growing up? What about your partner? Does your partner use or has a problem? What about you in the past before you got pregnant? What was your use like? And then you come into the present. What about the last month or last year? Or what about since you got pregnant? So kind of coming from the outside in an open, collaborative spirit. And once a person discloses use, then to follow it up with another quick screen about what kind of substances, how often, and I always like the questions then to ask. So what does it do for you? What are the benefits? What are your psychological, physical benefits of use? And can we start considering some alternatives? Maybe other substances or other treatments to offset that benefit, because using comes with a lot of negatives. So the urine drug test, it should be actually better called UDT and not UDS, what we do, but they're kind of, there are various tests, either for 6 substances, 8 substances. Now there's a newer one for 10 substances, because the originals did not detect alcohol and medications for opioid use disorder, which is buprenorphine or methadone. And what we all do when you do a screener, or this initial testing, that's why we call it screener, sometimes there is contamination. Sometimes, like for instance, if you take certain medicines, they might cross react with a substance of misuse, and the test comes back positive, and you want to confirm it. So that's why we do gas chromatography to confirm, was this a cross reaction? And in fact, it was a medication that was prescribed for something totally different, and or is it like trazodone, a sleeping pill, or is it really a exposure to a stimulant or that was not prescribed? So drug testing should be always done with consent. That's my bottom line, and then gas chromatography as confirmatory. What is the drug test helpful with? I use it to confirm the substances being used. I use it to confirm that somebody, if I prescribe buprenorphine, is really using the buprenorphine and not diverting. So I look at metabolites, because you can see if somebody's just, contaminating the urine with a little bit of buprenorphine, that's different. You can detect that because there are no metabolites of the buprenorphine in that urine. So you can confirm is really the person using that medicine that I'm prescribing, and to demonstrate engagement and share successes together of recovery, to seeing, oh, look, you are free of substances in the urine, or just the substances that we expect. It's not to diagnose. That's the important piece. So what about the newborn? So most commonly, it's performed in the meconium and that the detection, and that detects exposure of the fetus in the 2nd and 3rd trimester. Again, the positive test, meconium, just proves that the mother used and that the baby was exposed, not that the mother has a use disorder. And we have to say that there are very clear racial ethnic inequities. Who gets newborn tested, meconium tested? It's not universally distributed. So there's a lot of research to support that, and that is not something that we should be adhering to. Okay, so last kind of chapter, how do we provide care? What would be now, given all this, what you just heard, how would you approach the treatment? And as I kind of hopefully outlined is, once you have used opioids, particularly if you use IV use, so that the difference, whether you are, snorting or smoking, so through inhalation or through the nasal, there's a direct pathway from the nose into the brain. So that's why snorting is liked. But if you inhale, it goes through the capillaries through the lungs directly into the bloodstream and into the brain. If you IV inject, it's the fastest because you basically get the substance immediately into the circulation, and it goes into the bloodstream, into the brain, through the brain-blood barrier. These create this tolerance, this creates a sensitization of the receptors, and then if you stop it, these receptors are sensitized, they're maybe enhanced in number. So really stopping without any medical treatment is terribly difficult, because you have all these withdrawal symptoms that I will just share in a second. But we have medicines, we have analogs of opioids that we can use to do medication-assisted treatment for opioid use or medications for OUD. That's the gold standard. It improves the recovery rate, lowers the return to use rate, improves outcome with prenatal care. And to date, we have 3 medications. One is methadone, buprenorphine, and then naltrexone. And I want to briefly share how they are working, because they are very different types how they work. So these are the opioid receptors, right? And we have them in the brain. So this is an empty opioid receptor. It's all over the brain, mostly here in this middle area, the reward circuitry, but also in other, this whole area. Methadone is a full agonist. Methadone binds to the receptor and does the same thing as heroin would do. It binds to the receptor, but it stays kind of bound and basically covers the receptor, and you can titrate the dose, and that's how you prevent the withdrawal. And you slowly, over time, that takes a year or 2, you slowly could reduce the dosing, because slowly you are basically unsensitizing the receptors, and as the receptors proliferate in numbers, they slowly kind of shrink again in number. Then you have the opposite. You have naltrexone, which is an antagonist. It basically attaches to the receptor and blocks it, and so it's a full antagonist. There's no effect, and it blocks the effect. That's how naloxone is like the fast-acting antagonist. It immediately reverses the impact of heroin or any overdose with opioids, because you basically block get the drug off the receptor, and then you block it. And then you have a middle ground, a partial agonist, partial antagonist. It's a partial agonist, meaning that it adheres to the receptor. It binds to the receptor very potently. It's actually one of the strongest adherents, but it it has only a partial response. It flattens out the effect. So it is not euphoric. It does some analgesia, but it doesn't impact the respiration. So the effect is like halfway. So it's not an antagonist. I misspoke before. It's a partial agonist. It adheres to the receptor, but it only basically has like a 50% effect rate. And that generates a limited effect. That's what buprenorphine is. That's why you can, if you give it to someone who just used and you would give them buprenorphine within an hour, you might precipitate a withdrawal because it adheres to the receptor, and suddenly they have only go from 100% effect to 50%, and they notice that. So here, this is just a slide. I will share the slides with you where you have a little bit more data on in what formats it comes as tablet or liquid, the methadone, whereas buprenorphine comes as a strip, as film, as tablet, and now injectable like long depot, Sublocade, or naltrexone as tablets and injectable Vivitrol or Vivia. These are risks. And then what about the neonatal withdrawal rates? So if you use these substances, in pregnancy, if you give those medicines to the mother during the pregnancy, will the baby have a withdrawal from taking these substances? Yes, but to a much smaller rate than if they would continue to use, let's say, heroin or fentanyl. The neonatal withdrawal rates are like 90+% for illicit use, like with heroin, whereas they are higher for methadone. So the baby has a withdrawal. They drop down to buprenorphine. It's not dose dependent. We don't know who gets the neonatal withdrawal, who doesn't. Most likely there's a genetic kind of contribution from the baby's side. This is dose dependent. The higher the methadone rate, the more likely, and there is no withdrawal from naltrexone. Okay, why would we not actually do a medically supervised withdrawal in pregnancy? So there are different schools of thoughts, but in general, we are the clinicians working with pregnant people who are using opioids. We are recommending against getting off the substances without any medication assistance because the relapse rate is just so high. And that would then again lead to the infections, accidental overdose, and obstetrical complications. These are the withdrawal symptoms. I talked about that. So if you withdraw from opioids, all the things that you used opioids for the benefit, such as I have lower anxiety, I have no pain, less pain. You have now a lot of pain. And also you don't have euphoria, you have the opposite. You feel, you feel badly, you feel down, and then also in your body, because we said there's constipation. Now you have diarrhea, you have low blood pressure, you have elevated heart rate, because before you had, when you used, you have low heart rate. So it's basically the opposite. It flips, and people feel really badly. They have flu-like symptoms, and that might, push them to go back to use. This is how the baby experiences withdrawal. As said, there are different rates depending on what. So with continuous illicit use, the withdrawal for a baby is like 90% plus. And then we said with methadone, it's higher, with buprenorphine, it's lower. And we call it the neonatal opioid withdrawal symptoms. And these are the symptoms, very similar to the grown-up, with body shakes and poor feeding and breathing problems, rapid breathing, rapid heart rate, sweating, just being in pain, having this high pitched cry, having diarrhea, having stuffy nose. It's basically the neonate version of the withdrawal from in the adult. So what are we doing for that? In the past, we used the Finnegan scale to kind of, this is a scale where you measure and count the points, and the recommendation was to use medicines to, like, for example, opioids or barbiturates, phenobarb, to treat, and the babies were in the NICU for weeks and weeks. Now there's this new way of doing it with Eat Sleep Console, which is rooming in, feeding on demand, breastfeeding, calming, swaddling, shushing, rocking, lots of skin-to-skin contact, low stimulation, dim light, parental presence, a lot of body contact. Basically, the idea is if the baby can eat, sleep, and be consoled, we use these eat, sleep, console methods. And only if that would not be, then we could use PRN medicines like morphine to calm the baby. Important, recovery is a process. It's not a singular event, and the support needs are multidimensional. This is really important because this is the wraparound. Medicine alone is not enough. There is the way how we engage with the patients in terms of our words, trauma-informed, doing harm reduction, meeting the patient where the patient is at this point, and working with motivational interviewing towards lessening the use or discontinuing use, and then being aware of social drivers of health. So I just want to touch base briefly on these individuals. I really believe strongly, and we could have a whole seminar on words, that we don't use shaming, punishing, punitive words, and kind of check ourselves. Is our language engaging, loving, and kind? And so, like, just as a not to say, there's an addict, and but a person with use disorder, or a person, instead of, former addict, the person in recovery, things like that. Or when we talk about urine drug testing, that we say, the urine was substance free instead of it was clean, because that implies there's something dirty about the substances. Okay, so I told you about the social drivers of health, that this is a very important one. We think that 80% of the outcomes are happening outside the medical facility, in the life circumstances. And so with economic instability, poor education, poor access to healthcare, neighborhood violence, environmental safety or lack of, social community context, housing. Many of my patients are unhoused. There's so much instability that all contributes to the ability to recover and heal and comply with treatment. Very important, trauma. So 80% of the women in addiction treatment report history of physical and sexual assault. Women with OUD are 12 times more likely to have PTSD. And in fact, when you look at mental health comorbidity, there is no such thing as depression, alone, or PTSD. In individuals with substance use, the comorbid occurrence of PTSD, post-traumatic stress, based on trauma, either childhood or interpersonal violence later in life or ongoing, and other social determinants of health problems that then lead to depression, PTSD, anxiety, substance use, self-medication with substances that then develop to a use disorder, are just extremely high. So we have to treat all of it. The point is, don't just look at one side, look at the whole picture, from social determinants of health, housing, access to food, food insecurity, water insecurity, and to mental health. Also important to say, if, as you know, in the US, 1 out of 4 girls have been sexually or physically abused in childhood. And trauma, particularly early in life, changes your worldview. It changes relational trust. It changes your self-perception. So that leads then to emotional dysregulation and psychological isolation. You don't trust anyone. And then that's why you don't seek help. That's why they also don't come to prenatal care, or they don't engage in therapy, or they don't. So trauma work is super important because it also has ramifications for mental health, PTSD, depression, and then for parenting. And as you know, the children in foster care, the number one is children under the age of 1. The number one is neglect and abuse in the context often of parental substance use. So what are the principles of trauma-informed care? Understand trauma is common. Create safety when you work with patients. Be trustworthy and dependable. Do what you said you are going to do. Don't overpromise, but do what you said. Be collaborative. Be empowering. Use your words, in such that they are not disrespectful, punitive. Have compassion and empathy. And most importantly, also take care of yourself. This work is hard. And so you need to make sure that you don't burn out and become, maybe bitter and sarcastic, because that's a sign of our own wounds, because we are overburdened by the work. Harm reduction. There are many things to think about harm reduction, from naloxone but for me, as a prenatal care for pregnant persons with OUD, the number one of my first session is not to make the person to do the right thing, but to get the person back safely the next time. So that we establish a relationship, so that then I can start discussing maybe harm reduction strategies that might not mean immediately a total discontinuation of use, but maybe a use that has an added aspect of safety. So that could be even with, making sure that if you're postpartum, that your baby is cared for by someone else safely, another trusted adult who is not a non-user and is safe, before you then engage in use. So that's super important. Recovery work is teamwork. That's also kind of speaking to this. This is hard work, and many people kind of are engaged in this work, from social work to home visiting to, the WIC programs, peer recovery coaches, doulas, community health workers, counselors, doctors, nurses, you name it. And so just as an example, we created this clinic in here. That's clinic that I co-direct and I work in Ann Arbor, Michigan, at the University of Michigan. It's housed in the women's hospital, and we call it purposefully Partnering for the Future Clinic. We don't call it the OUD clinic or the substance use clinic or the high-risk maternal fetal medicine clinic, because these are already, how do you identify going to that clinic? No, you go to the clinic where you partner for the future, your own and your child's future. And this is for individuals with OUD, SUD, chronic pain on medicines. And it's a team approach. We have an OB-GYN. I'm the perinatal psychiatrist. I also do addiction medicine. We have social work. We have counselors, a program coordinator, peer recovery specialist. And we work also with anesthesiology, because, we want pain management discussions when, as you know, when you are on these medication-assisted treatments, your pain threshold during labor is changed. And so this needs to be discussed. Anticipatory, what will we do? How will we do it? Physical therapy, pediatrics, nursing, and then we have this consult team. So that's kind of just to summarize that it's so important. Clinical care, but then also education, not only to the patients and the families, but also to the other providers, the labor and delivery nurses, the other doctors, maybe the family doctor out in the community. We all need to be on the same page. We all need to have the same language. And respectful, loving, kind language. We do some research and we do a lot of engagement and kind of outreach and to the communities and the patients. And these are all the factors that I just said. So I want to end maybe, just for the last 3 minutes, and then we have a couple minutes time for questions. That would be how we talk about patients in our multidisciplinary kind of like team meeting before the clinic starts. Or then we discuss patients. And this would be Cindy, who came to OB at 14 weeks gestation after an ER admission for an overdose with fentanyl. And for the first few months of knowing her, so that was before before she actually engaged, she was not really interested. She already worked with primary care. She was not really interested in anything other than harm reduction activities. And she and her partner have worked to make their use safer. So they said, oh yeah. So that was like the first 2 months. She was like, oh, I don't need anything. I know I have naloxone, and I know I'm never using when I use clean needles. And kind of working with her on going from pre-contemplation to contemplation to initiate MOUD. And initially she was not motivated. She really didn't want that. But then she said, you know what, I want to bring my baby home. I want to actually, so I'm considering to start medication-assisted treatment. And that's where she was initiated kind of thinking about, let's do this in an inpatient setting. Because from an OB perspective, we discussed with her, well, you're not coming because of your continued use, you're not coming to antenatal testing visits. The baby is growth restricted on ultrasound. And it would be good if we could move towards this next kind of treatment approach from harm reduction only to starting you on buprenorphine. And she was agreeable to do that. From a psychiatric perspective, there's a lot of reasons why she's not trusting and why she doesn't want to go into the hospital. She has anxiety, nightmares, because she has a lot of PTSD stemming from childhood abuse and IPV from the prior relationship, and also major depression. And so kind of medication-wise, I added the prazosin to help with the nightmares. And she's also saying, I still have daytime anxiety. I'm still hypervigilant. I'm still kind of, all over. I have racing thoughts. I don't feel right. And we know that low dose, like quetiapine, Seroquel, which is a second generation antipsychotic, but we don't use this in antipsychotic doses, that is helpful in very low doses for anxiety and is compatible with pregnancy and safe. So that's where kind of starting with some medicines but again, gently leading with the symptoms that she says, want to have addressed. And she says, first the nightmares and then the anxiety. So moving in with those medicines. And then she says, well, I could imagine, and we talk about, actually, we need to talk about the trauma. We need to address that because that's in the way. And so social work and the therapist can start talking with her about trauma-focused therapeutic approaches, which we have plenty of and good ones. And you can already do them in pregnancy, but you will dose that depending on, how much calming and kind of emotion regulation work do you want to get started. First, you want to build that, kind of that muscle, that emotional muscle for emotion regulation before you go into the trauma work. Well, so this was just a snippet of how kind of a multidisciplinary approach can lead to, kind of a conceptualization for the person and the needs. And I think with that, I am done, and we have a couple minutes for questions. And I'm just wanting to say that I am gladly curate the questions that you have and that we cannot address in the next couple minutes. I'm happy to stay on 5 minutes later.
Well, thank you so much for the information. Very, very in-depth. Thank you so much. And we already have a lot of questions in the Q&A. So again, thank you so much for agreeing to staying on a little longer because I think the questions are going to keep coming. So We have in the Q&A, is peer support, lived experience, a part of the multidisciplinary team?
Yes, absolutely. And I could have gone on a whole session about this, but you saw it. Yes, the peer recovery coach is a team member. In fact, our peer recovery coach is also is a person with lived experience who is now part of the team and is trained. We believe in actually dually trained as a doula. So she's now also kind of, and she's actually the first contact, the first person to start a discussion often. When people come to the clinic, we sometimes see them in different pairings, like the OB might go in with the peer recovery coach, or I go with the OB, or I go with social work, or social work and peer recovery coach to go together. But it's absolutely the lived experience and the understanding and us learning, us physicians or us social workers or those who have not lived with addiction themselves, with their with own substance use disorder. We learn from her, and I think that this is tremendously important. So thank you for this question.
Um, Diane is asking, are both OD and withdrawal symptoms the same? Is there a measurable difference beyond emergent respiratory distress slash complications?
Um, Overdose and withdrawal is basically the opposite from each other. Overdose is when you have a lot of the substance in your system, and you basically what the substance does is now excessive. And when you remember that slide, what I said, what are opioids doing in the body? They cause the good stuff. You have euphoria, you have no pain, and you feel, more relaxed and less anxious. But it also has physical symptoms. It lowers the heart rate, it lowers the breathing rate, and it lowers the digestion. So the digestion doesn't matter. So you're constipated. Who cares? You don't die of that. But the lowered heart rate, bradycardia, if you have a heart rate of 20 suddenly, I mean, your blood stops pumping. There's no blood going to the brain. And that might be partially also, that's why you stop breathing. It's also centrally. A, there is no blood going to the brain, and B, the central breathing area in the brain slows down, and that's why you die. And naloxone reverses it. Withdrawal is now the reverse. So you have all the opposite. You have diarrhea. Again, diarrhea is uncomfortable, but it's not. You have more pain, you have more anxiety, you have more stress, and you have fast breathing, fast heart rate. So the withdrawal is the opposite of what the substance usually does. It's for every substance. It's not only opioids. Think about alcohol. Why are we drinking alcohol? Because it calms us. It makes us more relaxed. Well, if you are in alcohol withdrawal, you have the opposite. You are more distressed and agitated and anxious.
Okay.
I hope it makes sense.
What are some recommendations for multidisciplinary teams working with pregnant women and children?
Well, that's a good, I mean, this is a great question. And it's like I wish, ideally, I would say, please email me and let's meet. If you have a clinic or a clinic team and you would like to kind of brainstorm this more and have also give me your ideas. I mean, I think what I presented as an example, this partnering for the future clinic, be multidisciplinary, um, have, and then be also multimodal in your therapeutic approach. So give medicines, state-of-the-art medicine, state-of-the-art medical treatment, state-of-the-art social work support, state-of-the-art counseling, adhere to, but then also have an attitude of openness, and kindness and be trauma informed. Understand that everyone who comes through your door made a big effort to show up. They might have, the car might have broken down. I mean, all the women, when they come, our clinic starts at noon and is officially going till 4. Well, people have an appointment because that's what medical systems do. They give you an appointment at 1 o'clock. Well, some of the women, the car broke down, the ride didn't show up, whatever. If they come at 3:30, I'm not going to say you are too late, right? So how many clinics send people away because they say, well, you didn't come on time. You're 15 minutes over your starting time of your clinic. I value that they showed up. And if we stay longer as a team till 6, well, so it be. You made an effort to come here. We are going to make an effort to be here for you. So I think it's an inner, maybe that's contradictory to where our health system and our medicine these days goes. But I tell you, we need to lead with love and connection. People are struggling, are suffering now more than ever. We have so much unkindness in this world. And people are not using because they're bad people, because they say, oh, I want to be, women and people, but women specifically in the pregnancy, they want to be loving parents to their children. They want to make a change for their child, but they come with a backpack of a lot of trauma and adversity. And so supporting them, that's why I showed you the statistics on PTSD and trauma and social determinants of health. And I'm sure that you have that as well. I always think to myself, if we could undo poverty, we would have 80% of mental health problems fixed. But it's not going to happen because capitalism is on the rise. It's the opposite where we are going right now. So I'm sorry, I don't want to be political, but I have a hard time not to speak my truth.
And this question kind of goes into what you were saying. How do we create a better understanding of social determinants of health among healthcare workers slash providers?
Wow. Again, please reach out. Let's connect. Let's talk and brainstorm. I think it's living by example. If you do it and you show it and you live it, other people are, living by the model, right? You walk the walk, you don't just talk the talk. So that's one, doing a lot of outreach and teaching, talking. I mean, that's important. And yeah, I think, and then in terms of your own clinical practice, then also, screening for social determinants and addressing them and engaging and, educating yourself on motivational interviewing and on, how do I engage people? And then very, very important, I am a strong believer that teams also need reflective supervision. So our team has we need a space too, where we then can go and unload and say, oh my gosh, this is so burdensome. We're exhausted. So having spaces where you can decompress, whether it's having fun activities as a team or having times off or having hobbies that you can do, but also having reflective spaces for your team where you can brainstorm together and decompress. I think that that's really important. And again, we get sliced more and more productivity, right? RVUs or whatever system you are. Absolutely not. Work against it. Resist.
So powerful, the things you're saying. Okay, we have another question. I heard you say you check for connection between generational addiction. Does a family history slash genetics make the addiction more likely, or is it harder to treat because of family history?
Well, there's actually very great question, and I think you are speaking to the nature nurture, right? Because both is true. On one side, does a family history of substance use? We don't have, let me just make it clear, we do not have a single gene that is called addiction, right? There's not, one gene to test for or one, but we have some genetic, we know that substance use is familially transmitted, that in families with substance use, there's higher risk for substance use. And in part, that is genetically passed on as a vulnerability. You might not, you don't have a gene for addiction, but you might have a gene for emotional instability. Well, if I am a person who is emotionally unstable, I'm more likely to then self-medicate at some point with a substance. And once I start using a substance regularly, I'm more likely to develop physical dependence and then addiction, right? So that's the way how it goes. That's one. On the other side, now just assume that let's say I am this person who was born to parents who both had substance use issues and they were emotionally, kind of easily distressed. That's why they used. So now I have this vulnerability for emotional dysregulation genetically. I'm just less equipped to be kind of even keel. But at the same time, while I was growing up, when I was an infant and toddler and young child, when my parents were supposed to help me learn emotion regulation, learn skills, how to self-regulate, because that's what parenting is. No baby is born with the ability to be Zen, right? And to know how to emotion regulate. Parents teach that in day-to-day interactions by addressing the needs of this baby. Well, if the parents were checked out and couldn't do it, well, I didn't learn it. So now I don't know it either. So here I have the double whammy. I was born with a genetic vulnerability for emotional dysregulation, and I didn't learn how to emotion regulate as a baby and as a young child. So now I have two problems. And then maybe I was exposed to trauma, or, my parents even invited me to use with them. I mean, how many of my women, when they share their story, they were asked to use with the parent or were kind of introduced to use. Well, that's where you used when you learn strategies of self-regulation that are malfunctional, dysfunctional, it's a perfect storm. So what is the treatment then? As a grown-up, we try to teach you now strategies for self-regulation. That's the psychotherapeutic skill, whether it's DBT or CBT or with a trauma lens, not imposing it on people and saying, you're to blame that you don't know how to do this, but to say, I understand. I hear what happened to you. I hear you. And I've got your back. And I'm going to be here with you on your side, supporting you in learning it yourself and then teaching it to your baby. So I do a lot of psychotherapy, mother-child psychotherapy. We have groups. We call them Mom Power because the moms named them Mom Power. They don't want a group for disturbed moms. They want a name that's empowering. So Mom Power is a group for moms with mental health and parenting struggles with mental health and behavioral health, substance use problems.
Well, that is all the questions that we'll take today, but I'm going to hurry up and just read a few things from the chat. Someone says, I'm so empowered by this presentation. I knew most of this information, but the way you present makes it more meaningful and relevant and timely. Thank you. Another audience member says, best overtime minutes ever. I think we're gonna frame that one. So thank you so much for going 10 minutes over. And then thank you so much for the audience. We still have well over 200 on. Before we go,
amazing. Thank you so much. Thanks so much for having me.
I'm going to read a little something about our partner that is putting on this event, another great organization that we work with. The mission, Northeast Delta, is to serve as a catalyst for individuals by providing mental health, developmental disabilities, addictive disorders, prevention and wellness services to help them realize their full human potential by offering quality, excellent care with greater accessibility. Their vision is to build a unified Northeast Louisiana where individuals are thriving and reaching their full human potential. The three tenets that guide their actions are greater access to services, excellent customer service, and quality, competent care. If you want to stay up to date on all their programs and events, the best way to do that is to follow the Phoenix on social media through Facebook, YouTube, Instagram, LinkedIn, and X at NE Delta HSA, or you can visit their website, www.nedeltahsa.org. Thank you so much, Dr. Muzik. This was very informative and a lot of great takeaways, and lead by example. I think that is a great high level takeaway for everyone in this field. But thank you so much for leading by example, Dr. Muzik, and we will be in touch soon. Thank you,
Thank you.
everybody.
Bye.